Good evening, Facebook, and welcome to Wednesday Night Wellness Live. I'm Dr. Andrew Merrill here at Nightlight Chiropractic, and as promised, I have a special guest with me here this evening, Dr. Leela Sorokin. And we've known each other for a long, long time. We actually went to high school together in Maryland, Northern Maryland, back in the late 90s. But I have her here as a special guest this evening because I've been promising you for a few weeks that I was going to talk about coronavirus, about COVID-19 here, and I'm wildly underqualified to talk about that, but I know somebody who is much more qualified to talk about that, and so Dr. Leela here is going to help us out this evening, answering some of the most common questions that we're getting in the office, and telling a great story here. She's got a very compelling story that I'm gonna force her to tell again to me for you, because I think it's important to hear that part of it too. So we're working with about 250,000 people who have died here in the United States. About 1.5 million people worldwide is the estimate right now who have died from this disease. And there's recommendations out there that I think are being misconstrued or misinterpreted or maybe undermined by certain groups even. And we wanted to talk about some of those as well. So I prepared a short interview for her here this evening with some questions, but I wanted to leave enough time for you, the viewer. If you have questions, you can throw them right down there in the comments section, and we'll do our best to get to them as quickly as we can. So as everyone kind of gets settled in here and we get some viewership, I wanted you to maybe tell us a little bit about your background work-wise. So we'll kind of chop it that way.
Hi guys, I'm Dr. Leela Sorokin, and I'm an emergency physician here in Central Florida. I worked at Florida Hospital Altamont for quite a number of years, and I'm currently up in Claremont working at South Lake Emergency Room and working at the freestanding ER Blue Cedar up there.
Right, and so in your interaction in those departments, you are seeing professionally quite a few of those cases,
Lots
right?
of
I mean, a lot of that's coming in. Other stuff too. I think we were talking just a minute ago about some other stuff that you're seeing as normal, as a usual emergency room kind of operates, but COVID. So are we seeing a lot of COVID cases here in Central Florida? I mean, is the number jumping up? Are we having another spike or another peak here?
I don't know. You know, we did not get hit at all in the spring. We had a very, very mild spring compared to many areas like New York, like Detroit. So I think we got very lucky. Our big peak for us was in July. The numbers in July were through the roof, astronomical numbers, and then we kind of had a lull again, but it is the numbers in patients in both the Florida hospital system and the Orlando Health system. I've got friends in both systems are steadily climbing up again.
Yeah, and so I mean, maybe similar to and maybe different from a lot of other places in the country. Do we have enough space, equipment, PPE for all of this stuff? Is this a concern or not really?
We're okay right now. You know, in terms of the patients and space, and I kind of caveat with the right now. Like some of the hospitals, some of the major centers, because they're almost like referral centers, in some of the communities, some of the sicker patients aren't being able to care for, so they're going to referring them to like Orlando Health into the Advent Health South. Their ICUs are getting somewhat fuller.
Yeah.
But our numbers are still in the manageable amount, and we have enough gear. We call PPE, personal protective equipment, which is the gear that we're all putting on when we're going to the room.
Right.
But it takes a lot of PPE, for a patient. When you think about, these specialized masks and the gowns and the gloves, and if you're going back and forth in a room, I mean, you're using a tremendous amount of this equipment. And right now, we're okay here. In fact, Orlando Health does a great job of sending us updates about our equipment, the inventory, the numbers. So we're good right now.
Good. Real quick, and I'm kind of jumping around here a little bit, so bear with me, but these are questions that I'm getting a lot, so I kind of wanted to throw them to you too. Is there any truth to the notion that we're inflating cases? Is there any reason that you would say this is a COVID-19 positive case, right? None, right? It would just waste a lot of PPE and be hard for you.
I think we're undercounting.
You think so?
Oh, definitely. There's patients who've had lung findings, like CT scans, that it's called pathognomonic, like this is COVID lung, and the test comes back negative, and you're like, really? This is COVID. I mean, because it actually has a very distinct appearance on CT scan.
Gotcha.
To the point where the radiologists are almost calling it from scans. And that's very atypical for respiratory infections, to have this is what COVID looks like.
So this has a unique appearance on CT, enough that you can say without the test even coming back, this is most likely.
I don't care what your test says. This is COVID.
This is where we're treating it. All right. So on the topic of tests here, because this comes up all the time, we were just talking before we started rolling here. Rapid tests versus PCR, antigen, antibody, PCR. Can you separate out some of those tests for us? Can you make some sense of what we're testing, which one's better and why?
Okay. So for a quick answer, if you're very symptomatic, the rapid test is called an antigen test. And it's going to give you an answer that if it's positive and you have a strong suspicion, you got COVID. If it's negative, the problem is this test is only 60 or 70% accurate. It means it's going to miss about 30% of people. So if you're sick, you've got a fever, you've got a cough, you feel like crap, you've been exposed to someone who has COVID, you take the test and it's negative, I would go get a PCR because it's a more sensitive test.
Right.
But the antigen test isn't overcalling things. With the whole issue with Elon Musk saying, "Oh, I took the test and had 4 positive and 4 negative." Well, 2 positive, 2 negative. The positive tests were accurate. The negatives were false negatives, most likely.
So there's a danger there
Or
of being
false
called
negative,
a false
missing it.
negative.
So
Somebody
the
is positive that comes back negative and they continue on with their life, potentially infecting other people. Right. So the PCR test, the one that takes a few days to get back, still the best.
Still,
method for testing.
that's the most accurate. That's the most sensitive test.
Okay.
In terms of that. And then antibodies are what you form. Hopefully, if your immune system's working, a couple weeks later afterward, you may test for antibodies, and at that point, if you're so inclined, donate plasma and potentially help someone.
Good little plug for that. I like it. All right. So on to the next question that I'm getting all the time. We got to talk about quarantine periods. Like I see 10 days some places. I see 14 days some places, and that place is actually the same place, which is the CDC. How do we wrap our heads around how many days are you supposed to sit still if you're sick? How many days are you supposed to sit still if you might have gotten it somewhere? What are these real numbers?
Well, the issue part of it is nomenclature. We're using quarantine when it really should be quarantine for if you're exposed but you don't know if you have it, versus isolation where you have it and you're sick. Mm-hmm. So the problem with COVID is that it can have a really long incubation period. So it can be up to 14 days after an exposure until you get sick and show symptoms. So that's why we ask people, if you've got a known exposure to somebody at high risk, to please, for 14 days, avoid, stay at home as much as you can. If you have to go out, definitely wear a mask. Right. That's kind of the quarantine period, is that you could be getting sick. The difference is if you're known positive, say you're or either by test, symptoms, whatever, that's where the 10 days start.
Gotcha.
So somebody
from the day of symptoms.
From the day of symptoms. So there's 2 different parts to this. It's kind of like, when can I see my friends again? When can I go back to work?
Right.
If you're symptomatic and you get a test, 10 days from when your symptoms started, after that 10-day period, as long as you've had no fever for 24 hours and your symptoms have improved significantly, particularly the cough. Because sometimes one of the symptoms, the lack of taste and smell, can linger for a while. But as long as everything else is mostly gone and the no fever, you're considered to be not infectious. If you're an asymptomatic person and just took a test because you were exposed, that 10 days starts from your positive test. But if you're symptomatic, say that Monday you start feeling terrible, but you can't get tested till Thursday, your test comes back on Friday, your day 1 was Monday.
Gotcha. That clears it up, I think. If you got more questions, throw them in the comments here. We did have one question that came through just a minute ago, which was, is there any overlap between COVID-19 and the flu? Are we seeing a lot of these cases come through together where somebody's got both of these maybe?
That's our fear. Please get your flu shot, get your flu shot, get your flu shot. There have been cases. And back in the spring in particular, when flu season was winding down, I had a handful of patients who were positive for both. And unfortunately in the spring, we probably missed some because there was a misconception you could only have flu. Somehow flu would beat up coronavirus. You wouldn't have both of them. Not true. You can have co-infections.
Okay.
We're not in flu season yet, but that's honestly one of the biggest fears for us in the next few months.
Right, so get your flu shot, like you said, listen to it. So skipping on here just a little bit, and we haven't even disclosed here yet, the reason that you are probably in a unique position to talk about some of this is not just that professional side of seeing all of that, but also...
I'm not just a doctor, I was a patient as well. So I had COVID. I'm just recovered from it. I was positive the end of October 31st. And I've been asymptomatic for about as long as I was sick for as well. But yeah.
So tell us real quick, what were the first symptoms that you experienced, the worst symptoms, the easiest, the scariest, like, in your opinion? Now we're just talking about your perception as the patient.
For me, I would have what I would characterize as a very mild case, and I'm very lucky with that. I came down with some pretty horrific body aches, and probably the first fever I've had in a decade. For the first day, and at first I even thought, I was like, wow, I went too hard at the gym, and then I realized I haven't been in 3 days, and I really didn't go that hard my last day. I was like, it's probably not the gym. And then the body, like, to the point where just everything hurts, like, it was awful. So horrible body aches for a couple of days. Only had a fever the first day. After that, no fever. Though I was on a lot of Tylenol on the leave, so maybe there would have been a fever had I not been drugging myself from body aches. Then I got a really bad headache. So I had several days of a horrible headache, and a bit of sinus congestion and sinus pressure. Had a mild cough through it, but I didn't really have anything I'd call a scary symptom. I did not have any of the chest pain or shortness of breath, but I've got a good friend who, she's a peds ER doctor down in South Florida, and she was diagnosed the beginning of October. She's still out of work. She's still home because she is not recovered.
Right.
Her oxygen level drops when she walks, and it's a scary infection.
So, I mean, I guess to the viewer out there, as a patient, it's a unique experience, right? So,
Everybody's different.
Some people get better very quickly, get out of quarantine, get back to work very quickly. Some people have lingering symptoms that really...
That's a long COVID. There's some
yet.
really nasty long...
So, do you have lingering symptoms? Is there anything that still hasn't come back? Taste and smell?
Taste and smell is coming back. It is not back yet fully, but I am beginning to taste things again, which I'm really excited about.
Let's see here. So I was following your Facebook, and you mentioned some supplements you were taking, and we just got a question in here a minute ago. Taking zinc plus vitamin D plus vitamin C, can it prevent getting infected? What do you think?
I don't think there's good evidence for like prevention full scale, but I think that it's not a bad idea at all. In fact, there's some recommendations that I have from one of the another hospital about prophylaxis and treatment, and then if you're critically ill patients, in terms of using things such as vitamin C, vitamin D, zinc, the B vitamins. There's some evidence even for Pepcid. I'm not sure the mechanism. Melatonin, because melatonin I did not realize is actually a potent antioxidant. It's cellularly protective. And if you actually do have COVID, daily aspirin to help prevent clots.
Oh, I like those too. So she actually had posted this, and you probably can't see it because it's backwards, but I'm going to attach this file to the bottom here, this comment section, and this is exactly what she had put up about what to take to avoid getting it, potentially, what to take for mild symptoms, what to take for maybe some worse symptoms.
If you're hospitalized, they'll take care of that. This is actually what they're giving people in the hospital.
Are they really? So we're using some of this stuff in the hospital now. That's fantastic. Yeah. I really like hearing that. I did not know that. Yeah. Let's see. Are most people you see obese, elderly, or other things?
Everything. You know, I have had elderly patients in their 80s be fine at home. Like, I see them, and I'm like, you've got COVID, you know, and they look great. I've had, you know, younger people in their 20s and 30s who look like crap. You know, we are finding that for some reason obesity does seem to be a risk factor in terms of severity. Surprisingly, diabetes, more than asthma, is a risk factor in terms of severity. I'm not sure, you know, what that is and why, but men, smokers, all of those things seem to actually be a little worse. It's some of the things that in some ways are almost classic for most illnesses though too.
Sure. Same thing for flu, right?
Man flu.
Man flu. Let's see. So I wanted to ask you real quick about some of the other things that you guys, that have been talked about as not frontline defenses, in the hospital type defenses, like remdesivir, hydrochloroquine, ritonavir, and interferon?
Of those, the only one that's really panned out in terms of any benefit is remdesivir.
Okay.
And the data on it's been a little bit mixed. What they found is that it has shortened hospitalization in certain patients. The idea of did it help, has it saved lives? That's kind of up in the air. Like the mortality benefit, it's a little hard to say, but maybe it's not getting to the right people soon enough. it does seem to be more effective earlier on in the course. One of the few things that actually has shown a mortality benefit is if your oxygen levels are low, steroids help.
Okay.
If your oxygen levels are normal, steroids aren't going to be beneficial. And in fact, there's, because steroids suppress the immune system, you'd worry that it's suppressing your ability to fight it. So that's why
Better
we're
to
only
breathe, but
giving
more
the
likely to
patients.
die.
We're only giving the patients whose oxygen levels are low because that indicates that there's almost this hyperimmune response. Something's going on. We need to kind of tone it down.
Sure, and that kind of leads me into one of the last couple of questions I got. And thank you very much for your time here this evening. You're fantastic for coming on this show. You talked in your Facebook about elderberry and cytokine storm, and kind of put those two together for us real quick, and then maybe more about the cytokine storm and what that means for your immune system.
So elderberry is a really popular supplement for immune activation. And in fact, if you're looking for a preventative, I think there's no reason not to take elderberry. It's kind of preventative to help activate, strengthen the immune system. There's a concern, and it's somewhat theoretical because no one's shown an actual link, but because one of the things elderberry does is activates your cytokines, which are chemicals in your immune system that kind of rev up the immune system. That if you're actually sick with COVID, because hyperactive cytokines seem to be one of the mechanisms that the lung is damaged by, elderberry is not a good idea because you don't want to actually increase the cytokines. Cytokine storm is a term that's given when somebody seems to have an immune response that is way out of proportion to the infection, and the immune response itself is causing the damage. And that's one of the things we try to avoid when we worry about it. I mean, there's even now debate, is it truly cytokine storm causing lung damage? Is it the virus damaging itself? Some of the stuff is a little bit up for debate still, but I think that if you're looking for prophylaxis, elderberry. If you're actually positive, stay away from the elderberry.
Gotcha. All right, so I'm going to race through a couple quick questions for you. I don't have to go into a ton of detail here. Mandatory masks. What do you think, yay or nay?
God, yes. Please wear your
Mandatory
masks. Mandatory masks.
Okay.
There was back and forth, and part of it, honestly, the back and forth. Number one, there was some inappropriate political pressure being applied to the CDC, and some of the things that were put out under their name were not really signed off by any of them that were allowed to speak up. And also, part of that too was there was a shortage of gear, and they were trying to kind of say it's yeah.
We need to make sure we have enough masks.
Well,
The best advice for someone who has just recently come down with COVID. Best advice. What do you have for them?
Don't freak out. Rest, hydrate, buy a home pulse oximeter.
Oh, there you go. That's great.
Home pulse ox. Sat below 92, get to the hospital. Other than that, majority of people do absolutely fine.
Good.
But contact people that you know you were around the days before you were sick. Do your best to isolate from family if you can.
Good stuff. I like it. All right, so very, very last thing. Vaccines, right? So we're talking about vaccines every day on the news here. I mean, it sounds like they've got some pretty effective vaccines out there, multiple companies working on it. The scientific community has really come together in a fantastic way, in my opinion. What do you think about a timeline? I know you're not in a regulatory position here, but
I have no idea timeline.
as far as how effective it'll be and how quickly it might curtail the cases that you see in the ER?
The numbers, if they hold, when they're getting this 94.5% effective, 90% effective, those are tremendously high numbers. When we think about the flu vaccine every year, now granted the flu is attempting to cover multiple strains, you don't know what strain's going to be circulating. The flu is probably 50%, 60% in a good year effective. So 90%, you're looking at tremendous efficacy, which is be great. And timeline when they're going to approve it, I expect they'll be getting out soon for emergency use. Who needs it? For example, I just got over COVID. So in some ways, that whole idea of herd immunity, which is a terrible plan, but I'm somebody who has natural immunity, most likely. How long will it last? We don't know.
Right.
So once I've confirmed I have antibodies, I'm not going to be getting the vaccine because I'm going to save it for someone else. I have no problem getting it, I wouldn't mind, but I don't really need it because I should be immune for at least maybe 6 months.
Sure. And one of the other things that I talked about in a previous show, one of the only things that I've said about it is, if you're not willing to get your flu shot, don't be the first one in line for your COVID shot, right? Either you're all in on public health or you're not in on public health, and I think that
And then
it's
go
in
off to
everybody's
some other
interest.
island where you can not
Right.
affect
If you
me.
don't care about anybody else, just go somewhere else away from people.
Elsewhere.
Anyways, that's all I have for this evening. Thank you so much for watching. This is going to be up on that Facebook page and probably on YouTube and maybe eventually a blog once upon a time. Thank you so much, Dr. Leela, for coming in to sit with us here. Hopefully some of this information leaks out and it makes your job a little bit easier there in the emergency room.
Oh, big thing. Please do not come to the emergency room just for a coronavirus test. It is incredibly expensive for you, number one. You know, the amount of gear we have to waste to put on just to swab your nose is insane. And, you know, if you can't breathe, come to the emergency room. But if you're just here, I just would like to get a test, there's a lot of better ways to do it. CVS has tests, there's private companies that are doing tests. You know, the city of, Orlando still has testing sites.
And they're all the same tests, right, folks?
Yeah,
So whether you
so
get it to emergency
we're not-
room or one of these other facilities, it's all
We're
the same
sending
tests.
out all our coronavirus tests. You're not going to get a result from us for sometimes even longer than if you went to CVS.
Anyways, I will not see you folks next week for another Wednesday Night Wellness Live. I will see you in 2 weeks. Have a wonderful Thanksgiving. Thanks for watching. Be well and good night.
Stay safe, everybody.